Open the quick pressure monitor set and remove the contents onto a sterile field. Place the needle firmly onto the tapered chamber stem of the diaphragm chamber. Remove the cap on the pre-filled syringe and attach it to the opposite side of the stem. Open the cover of the monitor and place the chamber into the pressure monitor with the black surface down, and carefully push it until it is seated in place. Snap the cover of the monitor closed. Hold the needle at a 45-degree angle upwards and depress the plunger to purge the system of air. Do not allow saline to trickle down the needle into the transducer well. Turn the monitor on and check for a numeric reading to appear in the LCD window. Next, hold the device at the intended angle of insertion, press the 0 button, and after a few seconds, the display should read 00. The display must read 00 before continuing. For each additional measurement, the unit must be recalibrated to 0. This section will describe the general technique of using the Stryker pressure monitor. Subsequent sections of this video will review specific anatomic approaches to the various compartments of the body. In most situations, place the patient in the supine position with the affected extremity at the level of the heart. The patient should be positioned so that the needle may enter the skin at an angle perpendicular to the compartment being measured. Prepare the skin overlying the area with a cleansing agent such as povidone iodine or chlorhexidine. Place a wheel of local anesthetic such as 1% lidocaine over the needle entry site. Avoid injecting anesthetic into the deeper tissues such as the muscle and fascia. Doing so may falsely elevate the compartment pressure measurement. Assemble and calibrate the device as described in the previous section. Hold the pressure monitor parallel to the compartment being measured. Gently insert it through the skin to the desired depth. The proper depth of insertion will depend on the compartment being measured. These depths are discussed in detail in the subsequent sections of this video. Slowly inject 0.3 milliliters of saline into the compartment to equilibrate with the interstitial fluids. Wait for the display to reach equilibrium and record the resultant pressure. For each additional measurement, recalibrate the unit to 0 and repeat the process. The anterior compartment of the lower leg is the most frequent site of injury-associated compartment syndrome. Contents of the anterior compartment include the tibialis anterior, extensor hallucis longus, and extensor digitorum longus muscles, the deep peroneal nerve, and the anterior tibial artery. Place the patient supine on the stretcher. Palpate the anterior border of the tibia at the junction of the proximal and middle third of the lower leg. Needle entry occurs 1 centimeter lateral to the anterior border of the tibia, perpendicular to the skin. Insert the needle to a depth that allows a rise in pressure during digital external compression of the anterior compartment just proximal or distal to the needle insertion site, plantar flexion of the foot, and dorsiflexion of the foot. Contents of the posterior compartment include the tibialis posterior, flexor hallucis longus, and the flexor digitorum longus muscles, the tibial nerve, and the posterior tibial and peroneal arteries. Position the patient supine, with the legs slightly elevated off the stretcher if the clinical situation permits. Palpate the medial border of the tibia at the junction of the proximal and middle thirds of the lower leg. Needle entry occurs just posterior to the medial border of the tibia. Advance the needle perpendicularly to the skin toward the posterior border of the fibula to a depth of 2 to 4 centimeters. Confirm proper needle placement by observing a rise in pressure during toe extension and ankle eversion. Contents of the lateral compartment include the peroneus longus and peroneus brevis muscles, and the superficial peroneal nerve. Position the patient prone on the stretcher. Place the leg so it is slightly elevated off the stretcher. Palpate the posterior border of the fibula at the junction of the proximal and middle thirds of the lower leg. Needle entry occurs just anterior to the posterior border of the fibula. Advance the needle perpendicularly to the skin and directed toward the fibula to a depth of 1 to 1.5 centimeters. If the needle contacts bone, withdraw it 0.5 centimeters. Confirm proper needle placement by observing a rise in pressure during digital external compression of the lateral compartment just inferior or superior to the needle entry site, and on inversion of the foot and ankle. Contents of the superficial posterior compartment include the gastrocnemius and soleus muscles. Position the patient prone on the stretcher. Visualize a transverse line at the level of the junction between the proximal and middle thirds of the lower leg. Needle entry occurs at this level 3 to 5 centimeters on either side of the anatomic midline of the lower leg. Advance the needle perpendicular to the skin and direct it toward the center of the lower leg to a depth of 2 to 4 centimeters. Confirm proper needle placement by observing a rise in pressure during digital external compression of the posterior compartment just inferior or superior to the needle insertion point and dorsiflexion of the foot. Contents of the volar compartment include the flexor carpi ulnaris, flexor pollicus longus, flexor digitorum profundus, flexor digitorum superficialis, palmaris longus, and the flexor carpi radialis muscles. The ulnar, superficial radial, and median nerves, and the radial, ulnar, and anterior interosseous arteries. Position the patient supine on the stretcher with the arm at the level of the heart. Place the forearm in supination and identify the palmaris longus tendon and its proximal course. Needle insertion occurs just medial to the palmaris longus at the junction of the proximal and middle thirds of the forearm. Advance the needle perpendicularly to the skin and directed toward the posterior border of the ulna to a depth of 1 to 2 centimeters. Confirm proper needle placement by observing a rise in pressure during digital external compression of the volar compartment just proximal or distal to the needle insertion site and extension of the fingers and wrist. Contents of the dorsal compartment include the extensor pollicus longus, abductor pollicus longus, extensor digitorum, extensor digiti minimi, and the extensor carpi ulnaris muscles, the posterior interosseous nerve, and the posterior interosseous artery. Position the patient supine on the stretcher, palpate the posterior aspect of the ulna at the level of the junction between the proximal and middle thirds of the forearm. Needle entry occurs 1 to 2 centimeters lateral to the posterior aspect of the ulna. Advance the needle perpendicularly to the skin to a depth of 1 to 2 centimeters. Confirm proper needle placement by observing a rise in pressure during digital external compression of the dorsal compartment just proximal or distal to the needle insertion site, and flexion of the wrist or fingers. Contents of the mobile wad include the brachioradialis, the extensor carpi radialis brevis, and the extensor carpi radialis longus muscles. Position the patient supine on the stretcher with the arm held in supination. Identify the most lateral portions of the forearm at the level of the proximal and middle thirds of the forearm. Needle entry occurs at this level into the muscle tissue lateral to the radius. Advance the needle perpendicular to the skin to a depth of 1 to 1.5 centimeters. Confirm proper needle placement by observing a rise in pressure during digital external compression of the mobile wad just proximal or distal to the needle entry site, and during ulnar deviation of the wrist. Kompartman syndrome can occur rarely in other anatomic regions of the body, including the gluteal region and the foot. Approaches to these compartments are reviewed in the written portion of this chapter. Normal compartment pressures range from 0 to 18 millimeters of mercury. However, there is no consensus on what pressure mandates a fasciotomy. Decisions on appropriate treatments must be made on a case-by-case basis based on the clinical scenario and in consultation with an orthopedic surgeon. In general, compartment pressures that come within 20 to 30 millimeters of mercury of the diastolic blood pressure should be considered worrisome.